question on oxygenation regards like oxygen delivery system.
Sure.
Yeah, we saw different materials of oxygen therapy. And they are also on the screen. Do we know how to differentiate dosage and device needed and the advantage of each one? I think we have nasal plugs, we have face mask, we have face tent, we have venturi, we have non-breather mask, we have high flow nasal cannula. And then we know that with the nasal cannula, we can give 1 to 6 liters per minute. For face mask, 6 to 10 liters. For face tent, 10 to 15. Venturi can go from 5 to 15. Non-rebreather mask, 10 to 15. High flow nasal cannula from 21 to 100. Next slide. Okay, we have a question asking to choose the correct answer regarding the FiO2 delivered according to each oxygen delivery device. The A said nasal cannula can give 10 to 35%. Is it true or false?
False.
False. Do we agree, all of us? Can you hear me?
Yes,
We can hear you.
Yes. Simple fast mask can 35 to 35. True or false?
False.
There is one answering only. What about the others? Non-rebreather fast mask, 60 to 85%. True or false?
This one can be true. It is true.
True. Okay, we will discuss after. High flow nasal cannula, 21 to 100.
True.
Venturi mask, 24 to 60%. True or false?
I'm not sure.
Okay, IT, can you go to the previous slide and have a look? Because on the previous slide, you said that non-rebreather facial mask 60 to 85, but we saw that non-rebreather mask gives 80 to 95 as the FiO2.
Okay.
You see that high flow nasal cannula can give to, according to the slide, 21 to 100. Venturi also can give 24 to 60%. Meaning that the true answers we have, it's the rest to D and E. Do you see that?
Yes.
They are asking us choose the correct answers regarding the flow rate of the below oxygen delivery device. Nasal plugs 1 to 8 liters. True or false?
Maybe the IT team need to go with you on the slide because the slide we are seeing is the first one. I mean the second.
And you said we should go to the previous
third one.
Can we move forward? You asked us to go to the previous slide. So can we move forward now?
Yes.
Okay. Maybe nasal plug, choose the correct answers regarding the flow rate of the below oxygen delivery device. nasal plungs, 1 to 8 liters. True or false? Facial mask, 3 to 8 liters.
False.
Facial tent, 7 to 20 liters.
False.
True, false. Non-invasive facial mask, 9 to 25 liters.
False.
False.
High flow nasal cannula, up to 60 liters.
True.
Okay, we saw that nasal plungs, say 1 to 5 liters. Simple facial mask, 5 to 10 liters. Facial tent, 10 to 15 liters. Non-rebreather mask, 10 to 15 liters. And the high flow nasal cannula up to 60 liters.
Yes.
Okay, IT, can you move to the next slide? Tim, can you hear me?
Yes, we can hear you.
Okay. Is the next slide there? The type and different.
Yes.
Okay. We have been like looking those type of oxygen delivery materials, nasal cannula, nasal plungs, Venturi, high flow oxygen. Those, can you put the next slide where there is a draw of high flow nasal cannula? I know some of health settings they don't have, but maybe soon they'll be having some. Okay, those are like, if you go to the next slide, they are saying about, you will excuse me, my computer that didn't show my screen. It's why I'm
Is this the
trying
screen you
to
want?
get another computer
Dr.
that will be
Apollinaire,
using.
Dr. Apollinaire, the screen we have on is the different types of non-invasive
Yes.
oxygen therapy. Is that what you want?
Hello?
The screen that is up is different types of non-invasive oxygen therapy. Is that the screen that you want?
Oh, the screen of my computer is not showing anything. I don't know what's wrong with.
Okay, so what screen do you want us to have up? What slide do you want us to have up?
I think the one with the where there is a nasal cannula versus simple face mask, where there is a advantage of each of the tool we have to use.
Okay. The one that is different types of non-invasive.
Yes, they are showing every tool with the like advantage and disadvantage. For example, for nasal cannula, advantage is ideal for patient on long-term oxygen.
Yes, that's the
can use
screen we
them
have on. Please go ahead.
with a flow of 1 to 5 liters, which is not high flow. Yes, it's a right, and the patient is comfortable. He can speak, he can express himself, he can eat, he can drink. And then humidification of air is not required. The disadvantage, it cannot give high flow oxygen it can irritate the nasal mucosa. FiO2, it's low that can deliver. And then when you want to go above 5, the patient is uncomfortable. For the simple mask, advantage is less expensive, can be used in mouth breathers, someone who is breathing with mouth or nasal. Disadvantage, patients are uncomfortable, they cannot eat with that. Also, it has like a limited flow because it can go above 10. You can't eat or talk while having a facial mask, and the patient have to be in one position. That's disadvantage. Next slide. The next slide is showing the advantage and disadvantage of non-rebreather mask and the Venturi mask. As we saw, non-rebreather can deliver 10 to 15 liters, and it can keep the patient away of intubation. And disadvantage is expensive. Even if the oxygen is delivering is high, it not comfortable for patient because he can't eat, can't drink. If it's like to require long-term use, the patient will be tired. For Venturi, it's fine for the control of FiO2 because its FiO2 is regulated by the tubing, and then it can come from 21 to 100. It's fixed and reliable, and it gives a desired FiO2 you want. It gives a good flow, but it's advantage. I know one hospital with that Venturi. It's expensive, and it can't give high oxygen because the flow can go up to 50 liters, and it is interfering with eating, drinking. Next slide. There is a question asking which of the following is in the correct order for the least FiO2 to highest oxygen delivery. A, nasal plungs, simple mask, non-rebreather. B, simple mask, non-rebreather, nasal plungs. C, non-rebreather, nasal plungs, simple mask. D, nasal plungs, non-rebreather, simple mask. Which one is the correct?
Sí.
Hello?
Hello.
Okay, as we can see, we know that nasal plungs, the order A is correct. Nasal plungs, simple mask, non-rebreather, it gives nasal plungs. We saw that it can give up to 40 FiO2, simple mask up to 60, non-rebreather up to 95. Okay, the next slide. Do you see the next question?
Yes.
Okay. They are asking all the following are advantage of using a nasal cannula except is it used, low cost, is it is not reusable? Which one is the not in the
Ishimwe Samuel is
What's the answer?
Ishimwe Samuel is disturbing.
Kangarama. Kangarama.
Please, admin, Ishimwe Samuel is disturbing. Serge is disturbing.
Hello?
Bari kukureba mwana. Hello.
Hello?
Ishimwe
Hello.
Serge is disturbing.
How am I disturbing?
Your video and your audios.
Hello?
Hello.
Disturbing.
Yes, you can continue.
Please continue.
Okay. As we saw, the nasocannula is easy to use. It has a low cost. The patient can speak. That's also an advantage, and it can be reused. The except one easily dislodged because it cannot be dislodged. Okay, next slide. Which device among the following use a high flow system? Face mask with reservoir bag, simple face mask, high flow nasocannula, nasal plugs. Which one?
The true answer is C, I think.
Yes, high flow nasocannula can
Hello. Hello.
I think it is better to mute some participant because they are disturbing.
I think the time for the breakout room ends in the next 30 seconds.
Can you mute some participant, please?
Sure.
Joseph? Yes, Joseph.
Hello?
How can we be in the same room?
What?
How can we be in the same room?
Dr. Joseph, the breakout rooms have now ended. Now we are in the main session.
No, we have to rotate into 3 rooms. Okay.
So I was in the first room now. Which room is this one?
Yeah, they are saying is the general room. I think we have to rotate it 3 times. Okay. Bavia.
Sorry, can you please repeat that again?
Joseph,
So
we just create the breakout room only for 25 minutes. Now time
Yes.
is over. Everyone is in the main room.
Sorry, after 25, everyone is in the main room.
Yeah,
Yes.
because we set the time for 25 minutes for all rooms. Now time is over and we cannot extend the time. So everyone is in the main room.
Okay, can we go back to the breakout session? Because we used to become 25 minutes and the panelists move to other room, and after those 75 minutes, we come back to the main room. So it helps to cover our questions from different slides.
If Dr. Francois and Dr. Joseph, you are okay, maybe you can use this particular room to answer those particular questions.
So you mean to use the main room?
Yes, Dr. Joseph.
I think we will not have enough time. So because of the questions are many, and if we use the main room, we'll waste time, and while we could have time to separately ask some. There is a way to go back to different room, to that room. If I was in room 1 and I can go in 3, if I finish 3, I go in 2, so that we do that kind of rotation. And after 75 minutes, we come back to general room. What do you think?
Right now we cannot create again that room because we do not have track who was in which group.
Okay, let's go over. Dr. Joseph, can you help the audience to answer to questions in this general room? So the floor is to Dr. Joseph to answer some questions.
So, okay. Here I've got here three questions. Okay. Are you hearing me?
Yes, we hear you.
Okay. So here I've got three questions. The first one, someone asked about the definition of shunt. So another one asked about difference between anatomy and physiologic shunt. So the last one asked which are long-term complication of oxygen therapy. So let's start by an anatomic shunt. So this anatomic shunt is like a condition in which your blood that go from the right side of your heart to the left side. So that's anatomic shunt. On your heart, blood comes from right to left. That's its anatomic shunt. So a physiologic shunt, if I can summarize, it's a condition. Are you hearing me?
Yes, we hear you.
Okay. A physiological shunt is a condition which can occur when your non-ventilated alveoli remain perfused. So it means that functioning as a shunt. So of course, even through there's no an anatomical, it's not in the case of non-anatomical organs. So we might have an example. In case of lungs, the pulmonary shunt, which kind of the passage of the deoxygenated blood from the right side of your heart to the left without gas exchange participation in your pulmonary capillaries. So then another question, a definition of shunt. So shunt in the one word, it's a kind of, it's a communication. The shunt is a communication. There is referred to the anatomical or a physiological. So another one asked about long-term complication of oxygen, as we said before. Now, when the patient got a higher oxygen, we get some complications. We said like free radicals production, so and so on. So for long term oxygen supplement, really, this will lead, of course, for a patient or those free radicals. I'm using the internet, please. Are you hearing me?
Yeah, you can read even I shared the slides.
Are you hearing my voice?
Yes, we hear you. And the slide will be shared.
Good.
Do you see the slide?
Are you hearing me?
Yes, we hear you. Do you see the slide?
I'm not hearing you.
Do you see the slide shared on the group on the screen?
Are you hearing my voice?
Dr.
Yes,
Francois,
I hear
I
you.
think Dr.
Okay,
Joseph,
so thank you.
Dr. Francois, I
So-
think Dr. Joseph has network challenges. So if you would like to, please continue. Thank you.
Yes, welcome.
Okay,
So
so I came back. So on the long-term complication of oxygen, so a patient may have a kind of nasal dryness, skin irritation, primarily the space where your cannula and the tubing touches. And as we saw in this presentation here, we say very well oxygen toxicity.
Previous slides.
Previous slide.
Yeah, about
Okay.
the complication of oxygen therapy.
Okay, so I say very well supplemental oxygen, really it's crucial, and excessive inappropriate supplemental oxygen, as I said, it might contribute to higher mortality, that's toxicity. I said the kind of tracheobronchitis, tissues, alveolar damage, and I saw also some people who are at high risk of having oxygen toxicity, especially those patients need prolonged duration on high FiO2, or those patients with chronic lung disease. So I don't know if you got all answer I gave.
So you can continue about those radicals you were explaining to the next slide also, the release.
So we talked about or those free on a cellular injury, where I said hyperoxia may produce cellular injury through increased production of reactive oxygen intermediate. I say it's a kind of superoxide, peroxide, radical, and hydrogen. Of course, those are free radicals. I said that they react with and impair the function of essential intracellular macromolecule, which can result in cell death. Of course, they can promote a kind of inflammatory response to tissues. Then I said hyperoxia induced lung injuries, especially where the mucus plug, lung atelectasis, and secondary lung infections. Thank you.
Yeah, I think this is the correct answer. So you can keep going to answer other questions, bro.
Doctor, it seems someone has, Martin, please, could you type your question? Your hands are up.
Yeah. Wamahoro, the floor is at you. Wamahoro Martin, unmute and ask your question or use the chat. Yeah, Joseph, the floor is still at you.
I don't see another question in the chat.
I mean, you have prepared the slides.
What are you saying?
You see the screen?
Yes, I can see.
Yeah, there are those questions.
So I gave answers to those questions. So I said that how do we get oxygen to our cell? Maybe when I lost the network, you didn't hear me. So I said that, of course, difference between hypoxemia and hypoxia. I said that this hypoxemia is a decreased oxygen level at your blood, and hypoxia is a decreased oxygen at your tissues. Or I said that oxygen delivery is a kind of transport. We know very well the oxygen is delivered is transported by the blood. You know, the big part is bind on hemoglobin. Another one is in tissues. Of course, the oxygen consumption, it's really at the level of tissues. We are asking if your tissues really are ready to consume the available oxygen. Of course, today we detect our oxygen bind on hemoglobin by using ABG and a pulse oximetry. Right?
Yeah.
Okay. I think they are clear.
So those are the terms we are using when we are taking oxygen into our cells. They are those different terms. And hypoxemia, as we defined it, or is different from the hypoxia, because hypoxemia is in the blood, hypoxia is on the tissue where the oxygen have to be used. And the usage of that oxygen is also, and other terms of oxygen consumption at the level of tissue. Thank you. Next, please.
So this question for clinical detection of hypoxemia. So that's which of the following are not clinical sign or symptom of hypoxia. So we say that in the last presentation,
can you let the audience give us an answer? Just 2 minutes.
Yes, they may repeat, no problem. Someone around can try. Of course, they remember everything as we said before.
The question to the audience.
No question?
Yeah, the question has been answered on the screen. Have a comment on it.
So as I said before, of course, the answer is the C. A loss of smell and the taste. It's not a clinical presentation of hypoxemia, as you say. So, on the patient with hypoxia will of course present with tachypnea or dyspnea, of course with features of respiratory distress. Of course, the patient might be uttered even tachycardia. So this loss of taste of smell really, it's not including in the answer.
Next.
So we have the thought on this one, on kind of cause of hypoxia. So back, okay, that one. So where we said that last time, we classified those into four groups. Where the first one say hypoxemia, where we say where there is a low FiO2 allowed to a patient, or the patient in himself is hypoventilated. Another one was anemic, as I said before. You know, the hemoglobin is carrying your oxygen. When your hemoglobin level is low, you will get hypoxia because of loss of transport. And that will be ischemic, where we say that kind of diffusion impairment. And come back. Next. Okay. Where I tell you is toxic, where your tissues are not able to use the available oxygen, and this will lead to ventilation perfusion mismatch. Where we say, of course, in case of COPD or asthma attack, of course, in the case of shunt, anatomic shunt or physiologic shunt. So anatomics in the case of, for example, those congenital neonatal disease. Next, please.
There is a question in the chat. There is a question in the chat, Dr. Joseph.
Let's see. They're saying the chat is somewhat not visible. Maybe.
No, the previous one. How should differentiate hypoxemia and low SpO2 FiO2 of people from high altitude mountain or human with oldest years of life?
Okay, so for this question, so the first of all, let's understand hypoxemia. As I said, this hypoxemia is decreased your oxygen level in your blood. So for this SpO2 over FiO2, so maybe we should say FiO2 over your SpO2 ratio. So this they are a chart for a normal length for this ratio, and you will adjust this according to a patient. Your value from this ratio, then you compare our clinical information for a patient, and then you will get it that your FiO2 of course, a patient will be very sick, especially when this ratio will be high. The ratio will be high, really to indicate that this hypoxemia is from that.
What about mountain people? They say mountains in high altitude. Is it an influence, or there is any influence of being in high altitude?
Yes, the people from high altitude, they have the SpO2 is low because there's not enough oxygen. That will be hypoxia, because as I said before, the low FiO2 surrounding you, or when you are not able to get enough oxygen to your lungs, that will be hypoxia. I don't know if I get clear answer to this one called Jean-Felix.
You can continue. Your time is still to you, Dr. Joseph.
So on this level, that they need supplemental oxygen precaution. So we saw before in the team 1, we have said that the normal range of our oxygen saturation is between 90 to 94%. And remember our target of normal axial pressure of oxygen was between 60 to 80%. And of course, the goal of supplemental oxygen, as we said, is to get SpO2 above 90%. So then continue, please. Next. Next. Okay. So as we said, those factors which may interfere with the pulse oximeter, as we said also before, the right might.
So as we discussed, I think his internet connection has a problem. As we discussed in previous sessions, there are factors which you may consider when you are using the pulse oximeter, for which including the light, the movement of the patient, or the weak volume when the patient is hypovolemic, or you are having a weak pulse flow, so that the pulse oximeter cannot detect it. Other thing is when there is a toxicity, cytotoxicity like monoxide poisoning. At this time also you have to consider those things may interfere the interpretation of your results. So take care about those factors when you are reading the pulse oximeter. Next. The pulse oximeter reading, actually, when you are having a saturation between 70 to 100% is where you may be reliably consider the reading you are having. Below 70%, please, the consideration of SpO2 is not accurate. So take care of it, because in some circumstances, like severe hypoxemia or unreliable SpO2 tracing in hypoperfusion, so your reading is not correct. And when you have that, please, the consideration of those readings on pulse oximeter are not correlating and are not correct. So you have also to think about when you are assessing the risk of harm from hyperoxia, as we discussed above. People want to have 100% SpO2 oxygenation to the patient who is already in hypoperfusion state, and you increase the oxygen without thinking to the harm you will be having. So you have to correlate then at this time, you have to be doing ABG analysis so that you may correlate oxygen saturation in the blood and oxygen, I mean the hypoxemia in the blood, and also the hypoxia on the cell level by using blood gas. The blood gas will detect you the next, please. So our participation is not possible. Kindly type your question. Okay. So the audience will use the chat. As we said, there is kind of a consideration between oxygen saturation in hemoglobin and also the pulse pressure of oxygen, which we call commonly the hemoglobin dissociation curve or EDC. And there are some influence when we are having decreased affinity for HB to take oxygen, or increased affinity for HB to be on oxygen. This is called hemoglobin dissociated curve. We are not going into details on it at this time, but there is a video you can watch and get better about this oxygen dissociation curve, which is a step and important when you are going to interpret whether you are really having hypoxia while there is no hypoxemia. In this case of where you are comparing the patient who is in the previous category, we say. Let's use the chart. Okay, next, please. Next. What the principles of oxygen therapy monitoring? So you have to understand that when you are monitoring oxygen therapy, you have to consider it as other vital signs. And then when you are documenting the oxygen therapy target or effectiveness, you have to consider also delivering system, the flow rate you are giving, and SpO2 you are reading. So from here, we can give a message to our colleague and healthcare providers. Don't call and report I'm having an oxygen saturation of 90%, just and stop there, or you say 90% on high flow. So you have to tell us which high flow, that high flow on which delivery devices at that time, so you have a good communication to tell how oxygen saturation you are having when you give the 3. So if you are having in critical cases, you have to do arterial blood gas measurements in critically ill patient, because you cannot rely on just SpO2, as we found that there are some factors which may mislead you to that. Or you can also do blood gas in deteriorating oxygen saturation requiring to increase the FiO2, because as you increase the FiO2, you are also at increasing the risk of harming the patient by hyperoxia cell injury, as we discussed. Next, please. Here, there is a question. I need also to tap it in a pool and I see how you understand it. In which of the following situation should supplement oxygen therapy be started? You can pull it on the screen, please, and we see how they understand to the audience. Thank you. Thanks to everyone. Thanks to everyone. The answer is E. all of the above, because as we said, generally any patient below 94% who is sick and presented to your critical care setting, you can start giving oxygen therapy. So meaning from A, SpO2 less than 94, PaO2 less than 60, this is hypoxemia, because we define hypoxemia in terms of partial oxygen tension in the blood. And also patient is in respiratory distress and you are not able to monitor the SpO2. Please, at the health facilities, health centers, if you don't have the pulse oximeter, give oxygen. If you don't have oxygen and not pulse oximeter, as we are advocating for now, tell to your institution that you need them, and to, as we discussed in the previous, we need to build. When a patient is in shock, so all of the above has to be on oxygen. Next, please. When the basics, talking about oxygen delivery devices, some questions, oxygen target goal, when to give oxygen and how much to give oxygen, the flow be to Dr. Polinaire so that he can go through by discussion, taking consideration of the time remaining. Thank you. Apollinaire. Apollinaire.
Dr. Francois, please, we have a question.
Yeah. I see.
I would like to ask whether there's a relation between a fracture and hypoxia.
A very interesting question. Huh? Yeah. So in the meantime, we can unmute Dr. Polinaire so he start to present. So let me answer to this question from Serge. Whether there is a relation between a fracture and hypoxia. So to Mr. Ishimwe, Serge, I can say there is no relation between any fracture or hypoxia unless your fracture has led to what we call pulmonary embolism from the fact of that fracture, the fracture bone. Otherwise, a fracture, hypoxia, there is no any correlation between the two. Thank you. Time to Apollinaire now.
Okay, thank you very much. I had IT issues with my computer, but as I have been discussing with the questions on the oxygen delivery system, we'll be going through different type of invasive therapy, non-invasive, and the device we use to provide oxygen. Any member who can briefly give us type of non-invasive oxygen therapy he knows or she knows? Hello. Hello. Can you hear me?
Yes, we can hear you.
Yeah. Okay, next slide. Okay, for audience, choose the correct answer regarding FIO2 delivery for each of device we see. There is a nasocannula.
Let's pull again and see.
Okay.
Not question. The pool is not with the question.
No, they are. We are waiting, yeah.
Okay, not that one.
Now let's start by this when they're preparing the
Okay, no problem. Which of following is the, okay, which of following is the correct order for FiO2 to highest FiO2 delivery? Can you vote? Are they complicated or?
No one is trying.
Oh, what's wrong? Participant, what's your right answer? We are delaying. Okay, we can go through those ones. As we saw in the previous teachings, we saw that, okay, they are like some voting. We saw that nasal prongs can deliver the FiO2 of 25 to 40%. Simple mask, we saw that can give 40 to 60. Non-rebreather, 80 to 95. I think the correct order was nasal prong, simple mask, and non-rebreather. Because the nasal prongs, as we saw, can deliver up to 40, 25 to 40, mask 40 to 60%, and non-rebreather 80 to 95. Okay, next. Okay, choose the correct answer regarding the flow of oxygen delivery device. Can you make a poll for the question?
Hi, Oj. Oj, are you able to launch the poll from your end?
Sorry?
Dr. Apollinaire, I was referring to Oj. She is managing the launching of the polling questions.
Oh.
Kindly, I think you can continue Apollinaire because they don't have enough time to wait.
Okay, we are looking for different type of non-invasive materials we use to deliver oxygen. As we saw in the previous slide, we can use
nasal prongs or cannula or nasal cannula. We can use nasopharyngeal catheter. We can use mask. We can use mask with the reservoir. We can use Venturi. Next slide. We can use also high flow nasal cannula. I think maybe it's not common in our health settings, but soon they may have it. As you saw the drawing, the high flow nasal cannula have almost 4 parts, and it can humidify and regulate the temperature of oxygen delivered to the patient. Next slide. Okay, there you can see the advantage and the disadvantage of such device we use. For nasal cannula, it has like many advantages, and as you know, they have to be also disadvantage. For advantage, it's ideal for the patient on long-term oxygen therapy, because as you know, it is giving like a volume of 1 to 5 liters per minute. It's lightweight and comfortable. It's comfortable for the patient. The patient can speak with that one. He can eat or he can drink, and it doesn't require humidification, and it has a low cost. As a disadvantage, it is providing low flow oxygen. It can irritate the nasal and can cause a nasal obstruction. Its FiO2 is limited as long as the flow is limited. High flow rate, when you increase above 5, there is the patient is uncomfortable. For simple mask, as you can see, as a nasal cannula, it's less expensive, can be used in monthly breathers, not only for nasal. Disadvantage, it's uncomfortable for the patient as long as it's covering nasal in the mouth. It cannot permit the patient to eat or to talk. Also, it is delivering a limited oxygen flow and the oxygen and the FiO2. It requires also a tight seal so that the all oxygen is going immediately to the patient. Next slide, to see the advantage and the advantage of mask with reservoir or non-breather mask. It's as you know, it can give up to 15 liters. And if the patient comply with that, it can delay intubation. Suitable for spontaneous breathing patient with severe hypoxia, as long as you can deliver 15 liters. Disadvantage, they are like expensive than nasal prongs or mask. It's also, it have to be sealed. It interfere with eating and drinking and talking. Non-suitable for long-term use. For Venturi, it's we know that you can control the FiO2 and you can fix the flow. Also can be used with the high flow, and it can help to decide which oxygen level you want. As a disadvantage on Venturi, they are not more common. Their patients are uncomfortable. It's expensive also as other materials to give a limited FiO2. Also, it is interfering with eating and drinking as mask and the non-breather mask. Next slide. This question, we saw it.
as we saw, the flow, the order from least FiO2 to highest FiO2, it's a nasal plunge, simple mask, non-rebreather mask. Next slide. Okay, all the following are the advantage of using nasal cannula except. Can we make a poll for this question? Okay, someone is saying B. Other says C. Okay, because we are learning with time, as we know, the nasal cannula, I think they can be reused. But I see that C is false because because as you know, the nasal cannula, if you have seen patient with that, it is not easily dislodged because it's like it's touching the nose unless they are bigger than the, or they are smaller than the nose of someone. Okay, next slide. Which device among the following use high flow system? Okay, you can use a chat room to say the true answer. Serge saying C. Okay, Martin C. Félix Muremyi A. Joseline C. Okay, without delaying, as we know, the face mask with reservoir, it's a flow. If you can go on the previous slide or what you have seen, the face mask, it's the flow, it's between 5 to 10 liters. For the face simple mask, face mask with reservoir is 10 to 15. Simple mask, 5 to 10. High flow nasal cannula can go up to 60 liters. Nasal plunge, we saw that it has 1 to 5 liters, meaning that the one which can use high flow is the high flow nasal cannula. Next question or next slide. Okay, that's what is explaining. The standard nasal cannula, we saw that it's giving the flow 1 to 5 liters, and the FiO2 24 to 35 or 24 to 40, depends on the reference. Venturi can give FiO2 of 24 to 60. High flow nasal cannula can give up to 21 to 80 as a flow. Simple face mask can give 35 to 60. Non-rebreather can give FiO2 above 60, and it can, the flow is up to 15 liters. Next slide. During our presentation, we have been looking how a wake prone position
can help our physiology and of oxygenation. It improves oxygenation and improve respiratory mechanics. It can homogenize the pleural pressure gradient. It increase lung volume and reduce amount of atherosclerotic regions. It facilitates the drainage of secretion as long as someone is in a prone position, and it reduces ventilator-associated lung injury. You know that the posterior volume of lungs is higher than the anterior one, meaning that if you have a patient with difficulty in the oxygenation, prone position has shown that it can improve oxygenation. Next slide. Okay, this is a flow diagram of decision on a proning process. I think there is not too much to discuss about it as long as we saw the advantage of that prone position, as long as it reduces associated injury of lungs or infection, it's increasing oxygenation. That's a good position you can admit to our patient who are having difficulty in oxygenation. Next slide. Okay, how long should it take to SpO2 to improve? When should a patient be intubated and placed on a mechanical ventilator? Who has an idea on that? 1 minute, 5 minutes, 1 hour? Okay, maybe we'll get an answer after in the next slide. Next slide. No, there is as long as you saw that the patient, if there is indication for intubation and mechanical ventilation, because there is if our patient is hypoxic and he has a respiratory failure, if the patient is like having acidosis, and if our patient needs airway protection for people with low GCS, indication for intubation, if the patient is deteriorating on high flow oxygen or all maneuvers you did, as we saw, respiratory fatigue will come, and then patient with hemodynamic instability also will lead to intubation, or a patient with altered mental status. Next slide. The next slide will be looking when humidification needed in oxygen therapy and why humidification is needed. Humidification is needed because we want to prevent dryness of airway. And then if there is the airway are dry, they cause irritation of airways. Humidifiers are particularly effective in treating dryness of the skin, nose, throat, and the lips. We use water, distilled water or clean water to humidify our oxygen, meaning that there is an outlet attached to the oxygen that will be containing water that will be humidifying our oxygen. Next slide.
Okay, when oxygen is delivered, see, as we saw, when you are using a nasal plunge, because it's delivering a low flow oxygen, you don't need humidification. But when you are using a high flow, it will be better to humidify that oxygen. Again, the oxygen may be because the oxygen also is dry. If not humidified, it will dry the airway, meaning that humidification is necessary to prevent those dryness. Next slide. Okay, can humidification bottle be reused? Yes, those bottles can be reused, but after cleaning them. But sometimes you can find a single-use bottle to reduce transmission of infection. I think that's the end of my presentation. Maybe we are going on the basic of oxygen therapy in the time we have. Thank you. I think if there is a question, we will like have an answer at the end of this presentation. Okay, Serge asked, I would like to ask between spine and the prone position, that position to improve oxygenation. As we saw, prone position improve oxygenation. Also, Felix asked when SpO2 is still low on high flow oxygen device and the FiO2. Okay, I don't know what you want to ask, but when the SpO2 is low, you can increase the flow. Okay, thank you. If other questions, we are still accepting them. Let's keep with basic on the oxygenation. Maybe Xavier is having network issue. I can keep, as we know, we have been.
Is a meeting, is it unmute? I was talking unmuted. Thank you.
Okay.
Saying that the message is going to be talking about oxygen supplies, talking about wearing mask in this context of COVID. And that's the two messages from this presentation we are going to have. So all of us, as we know, in this COVID-19, every country, every corner on the world has experienced it. And the lack of oxygen in this period is really very, very crucial to the people, as the oxygen is the most critical medicine we have to consider. But to now is not all governments in all corners of the different countries have oxygen sources. I don't think how many oxygen cylinders you have in your health post, on your health center. So to this time, the government has to know how to invest in oxygen from the grassroots, even if possible from the community health workers with oxygen, portable oxygen cylinders. So this is a message, the importance of oxygen and having oxygen supplies in different ways. Next, please. Oxygen supplies in different ways.
We are having oxygen plants for rich people, but if you are in a low setting, low income setting, you can use oxygen concentrators. But as we know, the most common applicable is oxygen cylinders, which we are having. And when you are using this kind of oxygen supplies, you may consider the safety where they are. Next, please. The safety of oxygen cylinders is very important. Don't take oxygen, as all of us know, is an explosive. And once your cylinder is bursting, can create an explosion to your area. So if you are having oxygen around you, please think about the safety concern of that. In some areas where I visited, the oxygen cylinders are not fixed. They are in the ward with patients. So please, if you have the chance to have oxygen around you, also think about the safety concern it can create when it's misused or misplaced. Next, please. The time of wearing oxygen mask. Is rebreathing CO2 a problem with oxygen facial mask? The answer is no. The prolonged use of medical mask when properly worn does not cause CO2 intoxication nor oxygen deficiency. Around us, we are having these rumors. As long as we are wearing masks, next we have chronic lung disease, we will be having CO2 retention. Please, the MO2 statement is clear. If you wear it appropriately, there is no that concern of having CO2 breathing or oxygen deficiency in your body. Next, please. To this time, we are at the time of wearing the masks. We will see people around you. Today they have the same mask, tomorrow the same mask, or even some healthcare providers. They are using the same mask in different times. So in short, yes, you can do, but take care of the way you are managing your masks. So the self removal is very important. Don't touch where you will face to your face, so you can touch externally, and if possible, don't touch that externally. Remove the mask you have properly and keep around you if you want to use them again, because the majority of virus will be on the front, while when you touch inside the mask, you are moving those virus to that place so that you can cause harm to yourself. So as we are now having too much and too many masks in our settings, we use them in a different time, it's okay. Just to make sure you do it safely. The way you are removing, the way you are touching on the front of your masks, the way you are wearing it, don't extend the face. If the side is external, keep it external all the time. Don't change it and become to the face. Next, please. Yeah, it's the same what I was talking about, the danger of facial mask, the rumors circulating around us. There is no evidence saying the facial masks are not good. Next. To the time, children under 2 years are not allowed to wear the facial mask because their lungs are not fully developed. The people who are in respiratory conditions and they're struggling to breathe, please, you can relieve them from that. And also people who are in sports or doing some exercises are the people you can exempt to do wearing the facial mask. So in these three conditions, you cannot. This is a kind of reusing our materials. Dr. Pone talked about reusable humidifier water bottles, and now we are talking about a single-use equipment to be reused. Yes, in our condition, there is minimal evidence of problems in using these things and also having cross-infection to our patients. There are many talks about it,
But saying that you can reuse doesn't say is safe. If you want to reuse it, take care of them, clean them, and then reuse it, because rather than having zero, you can have reusable device around you. And take consideration ethics issue and legal issue, patient consent, and also policies and standards to your facility. Reusable equipment, take care of their safety. Next, please. Yeah, we are at the end. When you think to do reusable materials at your facility, as I conclude on, you have to think about the effectiveness of that. If in your facility you don't have single use, please, you can reuse it, but think about the safety and the quality of the device you have. Some of them has already are no longer appropriate to use. You will see some facial mask with dissolver. There is no longer those valves of exhalation and inhalation. In that time, they are not safe to the patients, and also they are not effective. So there is also cost benefits and risks. When we are using reusing a device, please think on those. And to me, the device I'm holding in my hands is the high flow nasal cannula, which may deliver 60% FiO2 to 100% to low oxygen flow. So if you are able to have such machine or such device around you, please use it. It's effective and is less cost because it doesn't consume too much oxygen and is good for a patient to whom I used it. They appreciated the device. I think the presentation from here, thank you. And if there is any question from the audience, put into the chat and then wait some communicate before we leave. Thank you.
Thank you so much, Dr. Francois. Please, if you have questions, kindly drop in your questions in the chat box. If you have questions, comments, please drop it in the chat box. Okay, if you don't have any question, we have previously shared the Learning Resource Center URL. Please kindly go there, register and access all of these resources for free. Thank you for staying with us to the end. Thank you to all the panelists for joining us today. We want to thank our partners, ECHO India and then Project ECHO for helping us with this. We want to thank Dr. Anna Crawford of the Division of Global Anesthesia, Stanford Medicine, for putting this together. We want to thank all our partners for making this resource possible, available, and then possible for us to share with the participants. Till we come your way next time.
Yeah, I have some comment, announcement before.
Okay,
Next
go ahead,
announcement.
please.
Yeah. So the announcement to the audience first is that we are ending up the first part of our 12 sessions on oxygen therapy and critical care. The first 4 sessions was focusing just on oxygen therapy and oxygen delivery devices. From the next time, we are now going into deeper how critical care are provided in any setting without thinking about you are in a higher referring facility, even where you are, you can give critical care service. So after these 4 sessions, any participant here who attended 3 out of 4 sessions is eligible to certificates. We're not going to talk about with the IT team how we can prepare them, and they may download them from your emails, because they have to check your attendance from the attendance list we are every day recording. That is one. The second is from the following sessions, we want to improve our way of working
So there are some questions or some I have about evaluation of our 4 sessions. What were your challenges you met during these 4 sessions so that we can see if we can address them? And what do you see we can change or we can do for better understanding and maintaining our audience? Because we started at 80, now we are in 46. So we want to see why those 40 went away without finishing our 12 sessions. How can we maintain the 46 who are remaining? So please, your comment and your feedback is welcome. Regarding the preferred language, 71% are preferring English, but as we told you, we are open in any language easy to you. You can use while asking question or answering. Every language is welcome to our hub. So this, I think, is what I wanted to give you like announcements. And as you see on the screen, our next appointment for session 5 is on December 15th, and we will be talking about critical care outside the ICU. Is what I was just briefing to you, that you can give critical care services without having an ICU around you. How will you do that? Is for the following sessions. So okay, and other other partners, please, the floor is up to you while we are waiting the feedback from the audience to my 2 questions. Thank you.
Thank you so much once more. Like you rightly said, our next session, session 15th, is on December 15th. And the topic is critical care outside the ICU, a rapid response. If you would like to follow while the session is going on, please, like I've earlier shared, go to the Learning Resource Center, register for free and access all the courses. If you have questions, please email us at echo@assistinternational.org, and then we'll respond to your questions. Thank you once more, and have a good day, everyone.
Dr. Och, can we end the session?
Sure.
Thank you, everyone.
Thank you.